Yep, with zero time to go.
That's okay. Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до Modern Brachytherapy course with ABS experts for Ukraine. My name is Natalia Kovalchuk and I'm a clinical professor at Stanford. I'm a co-founder, president of Help Ukraine Group. Help Ukraine Group, together with American Brachytherapy Society, or ABS, and SweetCare Support, organized this course to modernize brachytherapy services in Ukraine. And we are very grateful to Dr. Mitchell Kamravar, president of ABS, for supporting this initiative. We have an excellent set of instructors in this course, and we are very grateful to each of them for preparing the lectures, sharing their knowledge, and teaching us. This course, like all our other courses, will have AI-generated synchronous translation. You can turn on your translation by clicking on Show Captions in your Zoom window on the bottom, and translation, set your language, translated language, caption language to Ukrainian. So we have 144 participants in this course, 93 radiation oncologists, 45 medical physicists, 1 RTT, and 5 other specialties. 35% of participants have up to 5 years of experience in radiotherapy field, and 33% do not have any experience with brachytherapy. 20% have minimal experience up to 1 year in brachytherapy. And 30 RT centers out of 42 RT centers in Ukraine registered for this course. Most commonly used brachytherapy localizations are GYN, skin, and prostate. And the biggest barriers that was reported in brachytherapy use is lack of modern afterloaders, high cost of installation, source exchange, but also lack of training, lack of experience. And that's something we'd like to help with this course. And here's the course curriculum. So we have 10 sessions, 1.5 hours each, usually every Tuesday at 10 a.m. California time, but it's 8 p.m. in Ukraine. There are some exceptions for this rule. So you could see in red, there will be some lectures that would be on Friday. For example, November 4th lecture will be on Friday, and there will be 2 lectures in 1 week. So you could see Tuesday, November 18th, and Thursday, November 20th. And that's due to Thanksgiving weekend in Ukraine. We'll have a pre- and post-course test to track progress, and during each lecture, you will need to answer 5 multiple-choice questions. We will use these multiple-choice questions to also track your attendance, so please answer the questions. Please make sure your Zoom name corresponds to the name you would like to see on your certificates, because we check your attendance. We also applied for BPR credits. So at the end of the course, you will receive certificates with BPR credits if you complete your pre-course test and post-course test and attend at least 80% of lectures. So let's start with the introduction for today's lecture. Dr. Phillip Devlin, it's an honor for us to have him here. He is a professor of radiation oncology at Harvard Medical School and chief of division of brachytherapy in the Department of Radiation Oncology at Dana-Farber Brigham Cancer Center. He earned his medical degree at the University of Virginia School of Medicine in 1991, completed his residency in radiation oncology at the University of Pennsylvania in 1995. He followed by a specialized fellowship in brachytherapy at Memorial Sloan Kettering Cancer Center in 1996. Dr. Devlin joined the staff of Dana-Farber in 1997. In addition to lecturing extensively both nationally and internationally, Dr. Devlin established the Harvard Medical School annual brachytherapy review course. He has more than 100 published manuscripts and book chapters, and he is the editor of the Lippincott, Williams, and Wilkins text, a book called Brachytherapy, Applications and Techniques. Dr. Devlin is currently on the executive committees of both American Society for Radiation Oncology, or ASTRO, and the Massachusetts Radiological Society. He has been named a fellow of numerous societies, ASTRO, ACR, and also ABS. It's an honor for us to have him here and give this inaugural lecture of the course. And thank you so much for teaching us today, Dr. Devlin. I know you have a very busy schedule, very busy life, but you chose to spend this hour and a half with us. So we are very, very grateful. So his lecture will be on brachytherapy, clinical indications, and history. The podium is yours. I will stop sharing.
Thank you. Good evening. I have just eaten my lunch on the east coast of the United States and realized that some of you have not had your dinner yet. And I care about you and hope that you are doing well. The whole world looks on to the bombing and the war with sympathy, with wanting to be in solidarity with the Ukrainian people. And sometimes feel very helpless as to what I could actually do at all. So this was as a lovely invitation from Natalia herself and from the entire organization. I had dinner the other night with a woman who was born not far from there in Russia. And she was pretty tough on me, you know. She says, hey, listen, God gives you 2 ears and 1 mouth. So, Philip, you must listen more than you speak. So, in terms of a conversation and a dialogue, I would love to be stopped, halted, whatever you want to do. I'm happy to try to answer questions and have a conversation with each of you, and to give you enough contact so for afterwards we can do some follow-ups, and I'll say more about what I think we can contribute as well.
Thank you so much. I see, Dr. Devlin, that your language is not translating into Ukrainian. Do you mind looking into show captions and setting your language to English again?
Where was show captions again?
On the bottom of your screen.
Oh, yep, got it. Show captions.
And then there is a caret there. If you look at your language, my speaking language set to English, then it will be translating.
Okay, should I start again? Can you hear me?
Yes, it's translating. Yeah, perfect.
Okay.
No, that's okay. So you can share your slides now. Thank you so much.
Okay, yes, indeed. So what we're going to do is go to full presentation. Can you see my slides? Hello, Natalia? Can you see my slides?
Not yet. So on the bottom, there is a share button. First you share and then you put it in the presenter mode.
Got it. So I have to go out of, sorry about that.
Yeah, click escape and then share on the bottom.
Okay, so I have escaped. And then we have share. And I can see where I can share this. Good, share.
Yep, excellent. And put it in the presenter mode, we'll be all set.
Yeah, I'm going to put that one down. And then presenter mode.
Perfect.
Good. Can you see it all now?
Perfect.
Wonderful. Well, I just will say again how very thankful I am and how very humbled I am to be asked to address you as you seek to grow in the modern applications of brachytherapy with more availability for your patients, with living a life where you have people bombing you, and still nonetheless you have it in your heart that you want to be doctors and physicists and therapists and nurses who want to save people from suffering. And you know, it's okay for me sitting here in Massachusetts where I'm quite safe. I think that if I was sitting in Kiev tonight, and some drone rocket coming in at me, I would be I would be much distressed, and I recognize your valor, and I'm thrilled. So I was one of the people who surgically thought I would be a surgeon, and really didn't like it that much, but I had enough surgical skill so that everybody said, Philip, this was back in the 1990s, they said, Philip, there's this part of radiation therapy that nobody wants to do because nobody wants to be a surgeon. And so they literally said, you come to Penn, and then when you finish Penn, you go to Sloan Kettering, and you can remake brachytherapy with the people of your age group. And so the last 30 years has been pretty much that through mainly the American Brachytherapy Society, certainly through some of the European groups related to Jack Estro. And it has just been a beautiful time where you can look out now and say brachytherapy is modern, and that my generation helped to get that going. And I rather think the same is true in Ukraine, where there probably are people who have been there for 20, 30 years, who probably have, and I take my hat off to you for your courage and your endurance under difficult situations. Brachytherapy is my love. It is in my heart and in my mind, as the song goes. And I only do brachytherapy, and I do not have an external beam practice. But in the context of people trusting me 30 years ago, we were able to build a very universal program of very broad scope of essentially any brachytherapy there was some evidence for, even if we had to buy machinery, buy equipment, and argue our way forward with small studies and so forth. So I'm very much thrilled and enthused to be here. I'm going to move on just one slide. And then just to say that we are obliged in America, if we make any money from the subject we're talking about, we have to tell you. So they give you very little for medical textbooks. But the medical textbooks are useful. And in this modern era with all the AI, if we could have some way to maybe translate some of that, so that would be available in the Ukrainian language, I would be up for that. And I think we'd have to go back to the publisher to ask permission, but I don't think they're going to say no. So that's used. We also say, okay, there are clinical indications, and then there are off-label uses. Well, so I'm going to range anywhere I want to range for this, whether or not it happens to be the label. Now, I've got some questions, and I'm just going to ask Natalia, shall I roll into the first question, or shall I leave that for the chat?
If you want to, so is it in your
Right, it's the next
plan?
slide.
Want the next slide? Sounds good.
Okay, so we were asked to provide some questions, and I'm using the questions to teach a little bit. So on this, hold on, somebody else is
You can close this if you want.
yeah, is to sort of say there are things that we use or have been there for a while, and I'm wondering how it is that there is one of these is actually in the right order and all the others are wrong. So let's just have a look here now. So we write soft questions, so don't worry, nobody will get a bad answer here. So when do we think the first linear accelerator was created? Anybody guess at that? You can throw it in the chat or whatever you like. Any guesses? So the very first child treated with a linear accelerator was at Stanford, Dr. Kovalchuk, and it was in 1956, before even I was born. Okay, so that's 1956. Now, the CT scanner. What year was the CT scanner invented? Nobel Prize? Any guesses? Okay, 1974. And my colleague, Dr. Robert Cormack's father, Alan Cormack, shared the Nobel Prize in 74. Okay, so that was there.
That
Now,
was at Harvard. He's at Harvard, right?
no, he was at, no, Robert is at Harvard. His father was at Tufts, where Dr. Hansfeld was.
Got it.
Those were the powerhouse, yeah. And so the real personal people that they're still acknowledging that. Okay, even tougher, what about high dose rate afterloader? The difference between taking your hand and putting the iridium or whatever someplace and coming back and doing remote afterloading. Any takers for that one? Okay, well, it was not very far away from the megavoltage accelerator because it was 1958 and it was Dr. Ulrich Henschke at Memorial Hospital, became Memorial Sloan Kettering. And so that was the first afterloader. Okay.
And
Huh?
Dr. Devlin, so we have finished the poll. So 84% answered. I'm ending the poll and I'm sharing results so you'd be able to see. So majority actually answered option 2, radium, X-rays, HDR afterloader.
Oh, okay. So let's have a look at that now. So the radium, what year was the radium? Marie Curie.
It
The
was
radium
at the
was
beginning of 20th century, so
1898.
1998. Okay.
And what was the first year of the X-ray with Dr. Röntgen?
We actually think it's Polui, that's Ukrainian physicist, but it was 1906, I think.
So Röntgen, 1895. So 2 is not right just because of one little thing. 3
Oh,
years.
just 1 year before.
Yeah, X-rays was 3 years before radium.
3 years before, right? Okay.
Okay, now let's look at number 3. The high dose rate afterloader, we said was 1958. When was chemotherapy first given? About 1970s. So the afterloader had been like 12 years old by the time the chemotherapy came along. And remember that chemotherapy was incredibly old. And then X-rays, of course, were 1895. So the linear accelerator, well, let's go around the other way. So number 5, chemotherapy and X-rays is the wrong way around, right? So the chemo should be at the end. Right, okay. So number 4 says the linear accelerator, and that was 1956. The high dose rate afterloader, 1958, and the CAT scanner, 1974.
That's
So
correct.
that would be the correct answer. And how do we do? Just to see how we're doing.
Or in terms of answers?
Yeah.
No, so majority answered 2. So
Yeah, I know. And I think one thing to say in my confession is that sometimes I get very devious when I'm asking questions. So I'll just flip one thing. Anyway, so that's some of it then. And so I think the next slide sort of unwraps that. And we just think about and we give this dynamism is what we want to do. We want to give this dynamism to the technology that then developed all the stuff. We're going to see some of. I'm not going to give everybody else's lecture. I realize you've got cervix and prostate and skin and breast and everything. So I'm going to make sure I do not give anybody else's talk. Okay, so if we go forward one slide. Oh, I have to do it on the thing here. Sorry. Okay. Okay, so then laid out an easy format. Very importantly, that we give Röntgen the X-ray, Marie Curie the radium with Becquerel, who was her co-collaborator in the tar pits outside of Paris. We see that put in the hands of people like Marie's husband, Pierre Joliot, and there was early reports for I think benign prostatic hyperplasia of putting some radium up the urethra quite early. There are other ones as well, but just sort of showing how pretty soon after these things were discovered that they started to do therapeutic experiments for them. And then we'll come back to some of this, but then what did the atomic age give us? it gave us the ability to take inert heavy metals, dip them in the reactor, bombard them with a neutron or two, and make what is known as man-made isotope. Now, somewhere in the slides here, I wrote woman man-made isotope, just so we all feel equally engaged on the thing. But that really started an acceleration, so to speak, of technology where isotope could be many different things and many different applications, and it was much, much science. Not long after, the first linear accelerator was at Stanford, where Dr. What's his name again? Kaplan, Henry Kaplan, treated the first child with lymphoma, I believe it was. And so we have that. And then the Memorial Sloan Kettering first iridium was strongly only in gynecological for its very first number of years. And they still had the hand-pulled levers. So you go out of the patient's room, you shut the door, you pull the lever, and into the tandem and ovoid goes the chunk of iridium or whatever it was. So, as I like to say, as technology developed, the use of brachytherapy changed. Now, I think this is a question for you all. The next question. Okay, are we ready for a next question?
Sure.
So, where does brachytherapy not go? Okay, can you do the head and neck? Oh yeah, do you want to take the thing? You take the survey.
Yeah. So let people answer, and then we'll see what's the opinion.
Good. I like it. I like your style. It's nice and easy, laid back, which is so good. Is anybody?
So yeah, we have around 50% answering. So a little bit more answers, please. I'm just curious what people think. Yeah, and you're right. You're a little bit devious. You put some tricky questions. Okay, so we have 75% answering. I'm ending the poll, sharing results, and majority answered 4 that they think that you cannot do brachytherapy for blood vessels.
All right, so I just have to show you the next slide. Okay, hold on. Oh, no, which one was it now? There's this guy. Sorry. From head to toe, there ain't no place brachy can't go. So, and this I stole from my own lecture in 2022 when we had ABS in Denver, and the residents and the students went crazy with it. They thought that was hilarious. So going back to the question just for a second, we've got lots of slides and we'll stop when we need to. There is indeed brachytherapy for blood vessels for intimal hyperplasia. There were originally 7 randomized trials of coronary arteries, single metal stent, no drug on the stent, and anybody it didn't work for could get a bypass. Currently, we are back in this space, but very different, because now if you had one drug stent and it doesn't work, you get a second drug stent. And then you might get a third drug stent, and there's no place to stitch in your artery. So that place is a place where the addition of coronary brachytherapy adds survival to people who would otherwise have a heart attack and die. No operation available. So Devlin's thing, my mantra, right, there's nowhere brachy cannot go. So we know head and neck, but I thought blood vessels was going to be a devious one. And thank you. That's a good feedback. Okay, good. Okay, can we move on? And I'll just show you this. This is there's a sort of there's a song that goes with this as well. So we'll see how we do here, and if I can teach you a song, maybe. Never know. Okay, so let's go on, get serious here. My way of understanding is the whole of brachytherapy is divided in 3 things, which in English all begin with the letter G. Obviously, our gynecological practice, our genitourinary practice usually means prostate. So males, females, got it. And then the rest of this practice is a practice from the top of the head to the bottom of the foot, everywhere. Okay, now I'm going to play a trick the other way later on here. So just you have to keep watching. Okay, so now if I go forward, we see, oh, and why am I showing you this? So this is one of two books that were written by me and my team. I'd mentioned Dr. Robert Cormack, whose father co-invented the scanner. Caroline Holloway is a Canadian, and Alexandra Stewart is a Brit. And all of them world-class and hard-working people. And you have to tell you that I make money from consulting and stuff. Anyway, so and this book itself, I think we've got another slide on it, do we? No, no. This book has a fair amount of following in that we're looking essentially at every disease site. We're not just saying the book's about prostate, the book's about gynae. There is that. There's vascular. There's pediatrics. Who would think about doing brachytherapy on a child, you know? And so there's some excellent examples of that which we could talk about. You know, eyes and brains and you know, various parts like the not only the gynecological, you know, cervix, uterus, vulva, vagina, but also in the male of penis, skin of penis, mons pubis, all these other places where the surgical option would be devastating. And of course, we want to, both in the male and in the female, have a way to do something that stops the cancer, saves their life, but also saves the organ, saves the limb, and then finally saves its function. So with a very high bar to look and see where is it, but we can't go all the way with external beam. We can't go all the way with surgery. Chemo doesn't do it. And that's the impetus to push brachytherapy to be the referral sources. Okay? All right, now let's go forward. So you saw that. Okay. Hold on. It's not moving. Okay. Okay, so definition. Halfway down the page, brachios is Greek for short. And if you've met me, the thing to remember is I'm very short. And so short therapy, short doctor, okay? And the other Greek word is therapeutikos, which is treatment, care, and all the rest of it. But it has to be distinguished by our other good friend, telos therapeutikos, long therapy. As we know, a modern linear accelerator has a meter between the target and the central axis of the machine, right? So, and that then is called long therapy. And then the brachytherapy is you've got to go really into where we're going. So there are comparisons which are often made between brachytherapy and teletherapy. The therapeutic range in brachytherapy is just millimeters. It's short, got that, whereas opposed to the definition of an isocenter at 100 centimeters, a meter from away. We are surgical and procedural in our nature. Our external beam practice has become very cerebral, sitting in front of a computer with a thing called a mouse in front of you, not a scalpel or a trocar or some gizmo or other. Right, there's many different brachytherapies. We're going to look at just some today. You can fractionate or hypofractionate. There can be different dose rates for different ends. There are variable energies, which we're going to look at, and there's variable shielding allowed. And whereas the teletherapy, it's image guided, it's distance from the tumor, it often has to do many fractions. There is huge shielding, very expensive, and much normal bystander tissue may well get treated. So here's my trying to be, just so we need to have a look at that. There's another question, okay? You're doing good. So we'll ask the question, and that'll take us to our next little section here. Okay, so this is the question. Question 4. Include all except. You have on the American television a little jingle, dun 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 dun.
Oh, excellent. Bravo.
Oh, thank you. I do sing in a choir, and I'm very happy to do so. So, how are we doing on the voting?
So we have around 60% answering. So I have to make a disclaimer. Usually the way I met Dr. Devlin is in a Boston Symphony.
That's right. And she
Yeah.
was standing next to the most dashing Tomas Niedermeyer, and then looking to be quite the most dashing couple in the symphony. And I was so impressed, and still am. Okay, that's good.
Thank you. Thank you. So we have a majority of the answers, 83% answered, and then we have majority answering. It's kind of split between radium and strontium.
So both iridium and strontium are woman-man made. Cobalt 60 and iodine 125 are woman-man made. And radium was the one we dug up out of the ground. So
That's
the
right.
correct answer, I think, should be 3. Okay, it's just to sort of sense that in the history of this, weren't we lucky that we had these chemists? They were chemists, and Becquerel was looking for uranium and his science project, and Marie found radium, and she actually got the calculation wrong and still got a Nobel Prize. Yes, so it was the nuclear chemistry, I believe, was the calculation. Okay, so that's good. Now, with all of that, I just want to get you excited here because there's going to be a whole lot of stuff going on that we can do with all of this. Okay, so first of all, I've got to change the slides. So here we go. Let's see, come on. It's very tricky. There are very many types of therapeutic radiations. There are photons coming out of an X-ray machine we call an X-ray. There's the same photon coming out of a nuclear decay we call gamma. Both of these share no charge, no electrical charge. So electrons can come out of the machine, and there are some isotopes which give electrons, and they can be negatively charged usually in therapy, but they can also be positrons in diagnosis. So with a proton, I don't know whether we've gotten to protons in Afghanistan just yet, so in Ukraine rather just yet. I'll tell you about why I slipped there in a minute. But we've got lots of things we can come out of this, which are neutrons, alpha particles, carbon. And so I'm so excited by all of this. Now, depending on where people are, the next little bit of the show is a sort of a teaching bit to have people have a fundamental where we're going about it. And I'll go through it quickly. And if it's too simple, Natalia, please just say uncle. Okay, I will not be offended, but I find it very useful. So, starting with the photon coming out of a linear accelerator, it's an extrinsic electron displacing an inner shell electron. The outer shell replaces the displaced electron, and the energy difference is ejected as a chargeless wave particle energy, the conservation of energy. Good old Mr. Newton. That's very good. So that's very good. Now, getting eloquent now, gamma, in the struggle for interior inner peace, the nucleus undergoes collisions and transformations. These lead to a lower energy state for the nucleus, and the energy is ejected as a chargeless wave particle energy packet. Cool. Well, that seems so fundamental. But I think as we look and see what is going on down all of these different isotopes we're going to have a look at some of today, we have to kind of keep that basic raw science there. Okay, good. Okay. So radioactivity. Let's see. I think it's one of these ones I've got to keep clicking. Yeah. Okay. Isotopes are often made with neutron bombardment in the reactor. That's where we get our neutrons and how we change iridium 191 to 192. I think I may have shown that as my next thing. And then this is the more poetic in us, that our large unstable nucleus yearning for peace. You know, it's sort of like it's turmoil. It's yearning for peace. It's kind of like poor Ukraine, you know, yearning for peace. I know. So our nucleus is just like that. So as the nucleus decays, emanations come out to conserve mass and energy, and all of these things come out, alphas, betas, gammas, everything. Even something called bosons, which I don't really know what are, but I'm fine not knowing. So anyway, and counting principle. So with our beloved iridium-192, the neutron converts to a proton. So that's called beta minus decay. The mass is constant, the Z increases, and the negative beta particle and antineutrino are produced, and the energy comes out as gamma. So that's the reason, and I'll show you what this decay is like. Now, this next picture, you can lock your eyes like this, because this is the busiest picture we got, and it would scare you if we then asked you a question about it, okay? So this is worth looking at in this regard, so that the actual thing that's happening when you've got that iridium-192, and it's going to make its way down to something stable, not one thing, but like 20, 30, 40 things are going on in that. And so you have some richness of things that have a very short life, different level, of energy. And so the beta decay to the excited states of platinum and via the electron capture to osmium. So that gives us an average of 0.38, an average. And to think about this isotope as not mono energetic, but having a range of those things. Okay, so good. This is the tough stuff. Okay, so and I usually put that up for the residents, like at 7 o'clock in the morning, to say, can we rehearse this, and can we be you can sing it back to me by supper time. They say no. Okay, that's good. Okay. So these are all, obviously this nuclear age, they brought us the reactors, they brought good and they brought bad, of course, as we know. But then we got so many of these, we're not going to go through them all, but the P32, strontiums, yttrium, deuterium, and we've got lots of iodines, we've got lots of cesiums, we've got ytterbium, we've got gold, that's lead, which is now involved in theragnostics quite a lot, radium itself, cobalt, and ruthenium. I think that might be 106. Had a look at that. If anybody remembers, they can tell me. So just there's a whole lot of stuff out there. It's not just one thing, the iridium. And in the practice, so for instance, this morning, I used a strontium cardiac source. Somebody else was doing a prostate iodine case, and we also do cesium seed cases, which I use in the brain, as it happens. And then we don't have any cesium-137. That's kind of old and faded by now. But and we can get gold, but we don't have it. And then the radium, I don't know if anybody's got radium. Do you guys have radium? So maybe you shouldn't tell me even if you do. And ruthenium is to do with these eye plaques that are made out of the element, which you pop in for retinoblastoma and for choroidal melanoma. All right, we're moving along here. Okay, and then just to recite for the young people that the inverse square law is our dose is proportional to the square of the radius, and it gives us all the sweet stuff we want. And that's our major advantage here, to have a rapid dose fall off intensity as a function of distance, so you can be incredibly inhomogeneous and hot where you need to be and not pay a big price, which you would even with the most modern proton, the most modern adaptive care, the MR Linac. And that usually about now, I'll say, for us to understand and own up to the brachytherapy is the most conformal therapy. Okay, so they put it out there, and we can people can object if they want, but that's my view. Okay, so that's good. Sharp, I said all of that. Short duration, ultimate conformal therapy, and maybe we can accelerate dose in the hypoxic central areas of a tumor. Okay, the disadvantages. Radiation exposure has always been an issue. Afterloading takes it away. Shielding takes it away. People get hospitalized, little or no dose to adjacent tissue. You need to have a surgical sort of feel to you. It's not just the mouse. It is getting your hands washed up and getting in the operating room with your collaborating surgeons and other people to put applicators in. And there's loads of regulations. And they used to say that high dose rate and hypofractionation would have worse late effects to normal tissues. Well, You know, I think that was something that was held 30 years ago out of no knowledge, and I think it's not so held today. Which then calls me to ask you another question. You ready for one more? I think
Let's
you
do
told me
it.
fun. Let's just do it. Okay, my friends, hold on. Brachytherapy is integral to the care, sorry, there's somebody buzzing us here, of liver metastasis, breast cancer, uterine, cervix cancer, leukemia, and skin cancers. Which of those ones do you think?
So while people are answering, I asked the question in the chat, something that you asked, what isotopes are used in Ukraine. So
Yeah,
mostly iridium-92 and cobalt-60. Some institutions still use cobalt-60 and they are transitioning to iridium-192.
right. Yes. And what is the shape and size of the cobalt? Is it a micro source on a cable in an afterloader?
Yeah, I guess so. Mhm.
Yeah, no, so that's one of the things that when we were through a relationship that the Jack Estro had with what was then Nucleotron and Electa, became Electa, that was a relationship where we'd be talking to folks. Like one time I went down to Australia and we were talking to folks who come out of Myanmar, but like
Yeah.
with Burma, all the way down Indonesia, Papua New Guinea, Fiji, and New Zealand, and everything else. Like it's quite this, and that was the one they had, and so that's what we had to sort of work with and make sure we adjusted our understanding to do with dose rate effect, and all the many things that have. And I think having an international society, having interest, and collaborating with the manufacturers, I think is very good. Okay, how do we do with this one?
Okay, so 85% answered the question, amending the poll and sharing result, and majority,
All right.
84% said leukemia, finally.
Good students. Oh, see how we're getting better each time? There you
Yes.
go. There you go. Okay, good. So then that's good. We don't treat leukemia yet. I can only imagine that somebody will issue me a challenge to figure out what to do about it. You know, self-phoresis or something. Anyhow, so let's go on. And then, so I think this is just a summary list that modern uses of brachytherapy are integral to definitive and palliative care, gynae, uro, lung, head, neck, GI, from esophagus to anus, vascular, skin, and some endocrine diseases, such as thyroids and things. So it's a broad scope of what is brachytherapy in a world that likely, because of resources, 90% plus is working on cervix cancer, because that's what the issue is. And then the bits to do other things, there's not enough resource and room, maybe, but that we know it's there. And as things unfold, as people grow in skills, you know, they may growing skills, they will do and offer a broader range of services. So last week, having learnt to do sarcoma catheters, I hadn't in 5 years put sarcoma catheters in a positive margin on a sarcoma recurrence on somebody's forearm. Now, putting catheters in, stitching them with the surgeon, you know, and then doing all the work was quite a lot. But we still have those skills if we want them. Okay, good. Well, we're going to move on to some treatment planning for a little bit now. So you're getting the hang of it, but I've got another question. This is going to be a tough one. Now, here it is. Can you see it?
Yes.
Regarding treatment planning, how is all modern brachytherapy planned? Woohoo! You got some of these names may be name dropping. So I just want to take us through this the right answer, right? All the other stuff that was there before it, just to give perspective. We didn't crawl out from under a rock recently. It's been there over 120 years, right?
I like the abacus answer. That's awesome.
Well, you know, I think that when Marie Curie and Becquerel were figuring out the atomic weight of very heavy metals, they had a slide ruler.
Yeah.
You know, and they wrote the wrong numbers down. But anyway, it doesn't matter. So just to talk from that. So we said about 1906.
Yeah, so we have 80% answering, sharing the results. So
Oh, yeah.
80% answered
Good,
number one.
good students. Excellent, excellent, excellent. Now, but let's think about, it's one thing to do a hand calc and all the rest of it, but what is the significance to Patterson and Parker, two English guys, and then Edith Quimby, an American woman? So let me tell you a very fundamental difference, which will guide us as we look at what it is to be graphically optimized. So Patterson and Parker had isotopes of different strengths. They had strong, and they were radium needles, nothing else. Strong radium needles. And the rule there was to get a homogeneous dose across a target, you needed to put 2/3 of the dose at the periphery and 1/3 in the middle. And there are, books of tables of what that would be for, a 2-dimensional implant, 3-dimensional implant based on size and so forth. So even though as two guys who did have a slide rule, and they were sort of working very hard, they had all these different isotope strengths for them. What Elizabeth Quimby noticed at Memorial Hospital before it was Memorial Sloan Kettering, that all the radium and subsequently other things was of the same strength. And so the tables, which were Patterson and Parker's tables, those tables didn't quite match what she and that group felt was needed to what do you do with the same strength of sources. So you have something quite interesting, because if we look at modern, say, prostate low dose rate seeds, aren't we putting everything in the same activity and hoping we don't do bad things with it? Hopefully optimizing not to do bad things with it, right? But when we take the same prostate and we put high dose rate after loading catheters in it, and we do a high dose rate prostate, which you're going to hear all about in a proper lecture in a few weeks as well, that then starts to be much more like the Patterson Parker, and this sort of dynamism that's now coming out into dose volume histogram analysis of the target and organs at risk and all the rest of it. But it came from here. And so as the young people are thinking about it, it's worth, on a rainy day in February where you don't want to go out, to get the blow the dust off the book and have a look and have a read. They're well written. They are nice books. You don't have to do it, but to know that part of our history, I think, is something quite salutary. All right, good job. Hold on now, I'm doing all the talking here. Okay, we got a ways to go. How are we doing on the time?
It's great.
Okay, good. Yeah. Well, okay. So we did that. Hold on. This button is very trickery. So, I've just told you what I just said. We can skip that one. Modern treatment planning, computerized, graphically optimized for iridium mostly. Excellent, excellent. Okay, so we did that. Now, back to Devlin. My mantra is this, that brachytherapy is for complicated things. If you've got something that's not complicated, it could probably do it with something else. It could probably do it with surgery. You could do it with some. There's a reason it's complicated, because there's an organ or a function at risk. There's a big blood vessel right next to it. You're going to burst if you get it wrong. Okay, so and we're going to talk about superficial targets as well as deep targets as a sort of like a way to sort of divide our heads a bit. But I would like to sort of just show you, and I'm quite proud of that. Besides GU and GYN, we have found down 15 years that we are able to find new and prospective and high quality data telling us about the efficacy and the comparative efficacy in thoracic, gastrointestinal, esophagus to anus, which includes the liver, by the way, head and neck, in sarcomas, and you're going to hear about these breasts and pediatrics and skin and vascular. So that's like it's not just G and G. That'd be called 2G. We're very 3G. Okay. Okay, good. That's excellent. All righty. Now let's go forward a bit. And so, oh yes, you mentioned the first book, but I thought I'd mention the second one. That's it. Just give you a break mentally here for a second. Okay. Okay. Now let's just take a walk down some of the things that would be very, very, very straightforward and easy to do. Okay, so we have for the postoperative endometrial cancers that have a central component of risk postoperatively, we have the ability to put vaginal cylinders in place and then to treat them through the cylinder and with some level of planning or not. There is also that sort of outpatient style, but there's also lots of things that we can do in operating rooms. So this morning I did a yttrium 90 radioembolization, and I've got one to go and do at 4:30 as well. We use yttrium spheres in resin and yttrium spheres in glass, and we have both of those products available to us, covered by reasonable insurance, and we're able to then treat the on-label indication, which for glass is hepatocellular carcinoma classically, and for the surface it's typically metastatic disease, primarily colorectal, but having radiation in there. And wait till you hear the numbers of dose that you get. So it used to be the spheres were prescribed for 100 centigrade VLDR. Now the radio ablations are prescribing 400 and 500 gray, not centigrade, 400, 500 gray. And so my argument is you better keep radiation oncology in there just to see what is going on there. And so in the United States, I think we're in the minority. If they get to radio embo in the Ukraine, then I would encourage absolutely the radoncs to stay a part of the process. The pushing of 2 syringes is, it's not that dazzlingly stressful, but the calculating of dose and dose to normal bystander tissue, which are the liver itself hates radiation. If it shunts, it goes to the lungs and you get pneumonitis. And if it gets in a blood vessel and goes to the stomach, you bleed to death. So those 3 big, big, big risks. Radiation oncology has the opportunity at 400 gray to be involved and sort of set that standards. It's just very important. I don't know where that is in your part of the world, but I'm very much keen on that. Okay. This mouse is quite fussy. So this is just the first one, and I'm just going to show you this. It's a simple skinny blue catheter. It now is 5 French. It's a tiny little thing. It can go all kind of clever places, and I just want to show you a few of those. So here we go, like this. If we start, can you see my mouse on the screen when I move it? Can you see that? That I'm moving the mouse?
No.
No. Oh, well, if you look at the top left picture, there is a dummy strand in that blue tube, and it is coming down all the way to the first right turn of the right bronchus, which is the upper lobe bronchus. And radiation got a bad name in this disease because in the crux of that turn usually sits one of the pulmonary veins. And so beforehand, when they were just prescribing everything to a centimeter or half a centimeter, beforehand, they would dose too much and they would have bleed outs. So what we've been teaching around here is to very much optimize. And then so we use a very simple, the dwell positions along the way to paint dose. So no more than 100% of dose goes out to the area. And then down below, there's just some different shots of what that dose distribution looks like. And then on the up, oh, sorry, it's the next slide. Let me just compare that. If you can put 1 tube in, why not put 2 in? Huh? How about that? So here, what we've got is you can see how old this is, an X-ray, subcarinal mass, and the subcarinal mass can be treated by both catheters somewhat. Again, with optimization, the structure out the back is the esophagus, not a blood vessel. So you want to be very, very careful about that. And optimization is a good way to do that. All right. So this is just another one, a GI site of putting a catheter down the esophagus. They tend to go in the nose and drop all the way down. They tend to be thicker catheters because there were some hot spots when there were thinner catheters. And again, a normal role in palliation and looking very different. Just the next picture is actually, well, but hold on, wait. So, sorry, this, it's jumping. Sorry.
You can use the arrows, right?
I am using arrows, yeah. Yeah, the ones at the bottom, right?
Yeah. Mm-hmm.
Anyway, so this then shows you very poignantly, if you're doing a classic 4-field pre-IMRT dose distribution for esophagus for palliation, you get the pictures on the right with isodose lines of 70s, 80s, all the rest of it. And whereas you get a very rapid fall away with just a single source, again, in the palliation of esophagus. So if you can do it in the windpipe, where's the next neighborhood? Oh, come on. This is just not working the way I want it.
Mm-hmm.
And the next, sorry.
You want previous slide?
There it is. So now this is the name of this tumor. It's an inoperable tumor called a Klatskin tumor or cholangiocarcinoma at the conjoint area where the bile ducts and blood vessels reach. No surgery possible. Very, very dangerous. And so what we've been doing for these when we do get to see them is we've been putting either one catheter in percutaneously or two catheters percutaneously, and finding that that is a good way to get an intense dose over here. We then add that to some external beam, in which in the external beam world we are recognizing that liver does not like radiation and will crump very, very soon. And then using some brachytherapy to do the boost dose, so keeping the beam dose down to maybe 40 gray, something like this for the microscopic need. And that's been very, very well tolerated for bile duct cancer. Just again, whether or not these would come to you or not, Now, if you can do that with just a simple blue tube, how about this? And I take it nobody's done that in Ukraine, is that right? Yeah, so this handheld device has got strontium 90. Strontium 90 is a 30-year half-life. It gives about a megavolt of energy, and it's beta. It's pure beta. So, and there are 7 positive trials in the era of bare metal stents. And as I said, there still is a role for this where now they've got all the stents. There's no surgery left for them to do. If you look at the right-hand picture, those arrows, somebody's already been in there with a bypass and it's failed. So you can't really go back for that. This guy's also got a valve, and this is so cute. It's a little thing that feels like an old-fashioned cell phone, but half the weight of a brick. And you literally lever it forward and send the isotope round and down into the coronary artery. And then when you finish the time according to not quite an abacus, but not far off the abacus, it's a 6-monthly calibrated isotope. And I will say that when I came here in 1997, which was 27 or 8 years ago, the dwell for 23 gray at 2 millimeters was 3 minutes. You don't need to be a physicist to say he's got to stand there for 6 minutes now, right? And he does. That's quite something. But it does have a role. And then if we're doing that, I think the next thing is to ask you about peripheral artery. And sure enough, there are in Europe 6 randomized trials run and funded by the Nucleotron Corporation. Again, that same blue tube that's then put in this picture here. You've got the bifurcation of the common iliacs with in-stent restenosis and scar tissue. They clean it out, they radiate, it doesn't grow back. That's a really nifty in over 90% is a really, really nifty thing. Are you doing it in Ukraine? I doubt it. And I've only got one of the surgeons who believes in it here. They have supplanted this technology in with the drug-eluting balloon technology. Now, this is a way to give a chemotherapy medication off of a balloon that's put in the artery instead of putting radiation in. So, and I think the school is out on that, but it is there, and use of just those blue tubes, just the way I was showing you. Now, there's another thing, just to skip along here a bit, is this is a very unusual situation here. In this situation, these are radioactive iodine strands, which I have hand sewn into a vicryl mesh, an absorbable mesh, to put them somewhere. And now, 20 years later, now you can buy them pre-made. You couldn't buy them back then. So my 20 plus years of having brachytherapy fellows, I think they all lost a few hairs off the back of their hand for building these things. And so they basically look like this, and then they come out of these shielded rings, and then you can, using long handled scissors and allowing adequate margins for a suture. So an example of that, I think I got a lung cancer example of that, was the idea that you'd had a locally advanced tumor or a recurrent tumor, and the amount of dose you can give with external radiation is nowhere near tumoricidal dose. And in that setting, how can you give more dose? Can you go back? Can you put catheters in? And this happens to be very expedient. It's the same iodine as the prostate. It just comes in a carrier form of vicryl absorbable suture. Okay, so that's something else. All right. Now, moving along, we can then see what that looks like. Yeah, that's the teaching people not to pick it up with their fingers. You know, people are curious. And so if you look on the right side, sorry, if you look at the next slide, I'm sorry. If you look at the right side, this is what you want to look at, this very intense. This is what's called a Pancoast tumor. This is an upper sulcus tumor that often gets preoperative chemo, rad, and now immuno, but often leaves a positive margin of viable tumor right there at the resection site. And you can see the dose wash here falling off incredibly rapidly from it being 150 gray essentially at the seeds to it being down to 20 to 50 gray, just a centimeter or so away. Okay, so that's another sort of thing that we can do as well with all of these different equipment that we have. And now I wanted to just show you, I think you had been into this room, Natalia, at the Brigham, and when you guys were here, and that's there now. We're in a second room, so we have 2 afterloaders, and we got kicked out of that for a reconstruction, and so we're sort of not kicked out, but sort of like, sometimes we're here at 8 o'clock. That's how it is. Anyway, so going right along, so I'm trying to remember what I said. Well, we know how to do high dose rate treatments and hooking stuff up, so we won't stop with those. This is the second brachytherapy unit with its own wide bore CT scan, and that's the anesthesiologist hiding behind there. And really sort of figure that one of the things about doing advanced brachytherapy really is that you can have the anesthesia for you and with you. And that has been something we've championed down the years. The anesthesiologists adore coming to brachytherapy. It's easy for them. And so they do come and they're with us and building suites wherever people are going. Trainees come to us for a year, 2 years, and when they go home, they're building suites so that the propagation, if you like, of the brachytherapy continues to grow. And you can just see that is just in the next picture. You're just going to see that we've got 2 different situations of one looks like a prostate case on the left, and then the other one very much looks like a gynae case on the right of being able to do beautiful optimization. There's another picture of that with an MR fusion, I think, to follow, showing you very much how the modern way of doing, say, cervix cancer is this embrace philosophy that we are adopting of image guidance, MRI image guidance. and then adding a risk-adjusted contouring and setting of dose levels. Very, very lovely. Okay, so then I'm going to go on. We're going to, well, I think we'll just go past the prostate. You're going to get a whole talk on that. And we actually, this is just to tell you, we did a partial prostate study in the MRI with Dr. D'Amico 30 years ago. And so he wrote the 5-year paper, and it was wonderful. But it's sort of tucked in at 10, whereas now it wasn't any advantage to doing it. So it's gone away from what we normally try to do in a low stage, low risk setting. But it does have a role as we are asked to do salvage after previous therapy or even salvage after surgery, still have a role to do image guided interstitial brachytherapy. Okay, so now there's lots of things there. I feel like it's time for another question, but I can't remember what's coming. So complicated brachytherapy, that just to talk about, you're going to hear about these. I think you're going to hear a head and neck talk too, aren't you?
No,
No?
sorry, no head and neck.
Oh, so this is something that there's a picture of one of us hand loading iridium at Memorial Hospital. So it's coming around a million years ago, where you go to the operating room and you put a needle up through this way, reach it out in the mouth and go in and pull catheters all the way down there. And you see a beautiful, what you can do with this dose distribution. This is the Massachusetts General Hospital's technique, as I have with Dr. Bassi, who was over there and taught us all how to be very elegant and tidy surgical implanters. And seeing this dose cloud, the 100% dose cloud, being this blue wraparound, while really there's being no significant dose onto the mandible, most importantly, because of the risk of a necrosis on the mandible. So it's just beautiful. And then there's another version of the same, and that's another version of the same. Now, I'd like to go to an area you are going to visit, but I'd like to visit a different place. Most of the skin cancer that comes in the door to most places is going to be the skin cancer from sunshine exposure. And so you can use Mohs surgery. I don't know, do much Mohs surgery in Ukraine? I bet they do. And that's usually, and that should be the early stage low risk does not belong in an oncologist's office. The Mohs surgeons do a fine job, and you only want to see people when they've got some other issues, right? And so this particular gentleman was the first gentleman that we took on as an inoperable angiosarcoma patient. So the angiosarcoma, if you haven't heard much about it, is the meanest of all of the skin cancers. And in that, you can try to do a surgery, and even looks like no matter how many times you cut, you will always have a positive margin. And so the idea about using radiation to a high dose and using it with a very superficial is so we can push the dose higher, and then also ourselves spare the brain underneath in this setting. So I just want to show you how this sort of gets going here. So that's a picture of that dose distribution of this 50 to 75% just inside the cranium there. And so, and the 50% is green. And we wrote a paper which analyzed all of the VMAT we had done and the surface brachytherapy we had done by one of our docs who's now in Texas. And she found that for posterior lesions, you can do pretty good with, say, VMAT. But she found that for anterior lesions, the interference with the eye made it such that brachytherapy was much better. So we tend to look at these folks, and if they are further forward, we would then look at them for brachytherapy as their boost, as their therapy after having had a positive margin resection. How are we doing on time? I don't see any clocks. Oh, okay. So I've got 20 minutes.
Yeah, 20 minutes.
Okay, we should. Okay, so here we go. Let's just look at this again. Now, this is another one, and this is also a superficial sarcoma of the foot. And it's such a place in the foot that every approach from photons, an IMRT, and electrons would give her, in this setting, a chronic edema and pain from even if she was cured her cancer. And so with this being the postoperative wound, positive margin, high-grade sarcoma, then we would then do something in this setting like this, and starting to introduce this idea of complicated superficial shapes, where you can see this is wood. Somebody went out and got some wood in the backyard and sort of rigged this up together with aquaplast, with the Freiberg flap, and with some foot mold, so that the foot would be in the same position every day. And then, so this is very successful, and she's still walking on that foot today. So that's another use. All I'm saying is, see again on the top, I'm going to show you the dose distribution again here. This is the dose distribution beautifully along the way there, with great sparing of all of this. So you can't see the whole of the sole side of the foot is completely spare any meaningful radiation. So this is a really, really good way to do this. Okay, so a bit more. This is just the same thing, and thinking about what you would do if you did external beam radiation therapy. So this then, just to show you some more, is an airline pilot. And this is another sarcoma that has had basically a skin graft put on the top of that. Now, if I tell our plastic surgeons we're going to radiate your new skin graft, they tell me no, okay? They tell me, no, you can't. In fact, the one I treated last week, we didn't put a skin graft on him. We put a vac pack on him. We will radiate him this week, and then we will put the skin graft on the next week. And if it doesn't work, it's not my fault. Anyway, but no, we want the right thing to happen. But what I want you to do is look down at those cute and clever little dose distributions in the bottom right picture. You really can do such elegant dose distributions with a few interstitial catheters and a sort of a bit of creativity in the whole situation. Okay, so that's that. And I just want to show you an even more esoteric one. This was a concert pianist. And she was very, very, amazed that she had a wonderful career. She had a recurrent epithelioid sarcoma 11 years earlier. She got an excision, 45 gray, and then for the positive margin, this is done by Dr. Tom Delaney at the Mass General Hospital, as it happened. And there's a beautiful little implant, and I don't think we have the I don't think we have the dosimetry for that. So moving on, we're not just going to scooch over this, that you will receive a full education from it's Doreen Todor and from is it Katie? I forget who it is. Where they'll talk about all of this, and so there's some of the thing, and as you know, the B39 partial breast is still there. You know this well enough, and they're going to teach it. Won't teach it again. But I like to have people think about this as one way to do breast therapy, and then I like to, which I think was one of the arms of that trial. It was called Mammocyte, and there are subsequent generations. Has that happened in Ukraine? No, I don't think so. No, and then this, where you've got 3 decks of interstitial catheters with an in and an out. So the question would be, just to go back, I should have written a question about this. This is a good question. Is it better to have a single source, single position, or is it better to have many positions? I wonder what people think about that. It was the fine thing, my own experience with the Mammocyte, that this dose cloud is 1 centimeter away from the cavity. And whenever it was very superficial, there would be a dense fibrosis come around it, such that it was hard to read a mammogram, hard to do a physical exam, hard to do the patient's own breast self-exam. And so we really let that fall out of favor. And we will do these ones if there's no other option for whatever the reason, very, very rarely. But that would be how I would then say, the argument being many, many, many dwell positions, you can optimize. The more dwells, the more you can optimize. 1 dwell, non-negotiable. right? So that's just like a philosophy about how all of that goes. All right, so let's just see. So something also in the world here may be something of this the disposable electronic X-ray source with up to 50 kV operating potential. Has that arrived? Are people doing that in the Ukraine?
No.
No, none at all. So I think it had a few runs of it. There was one balloon for the breast was attached to that. I think there was one application where somebody did something like that and put it in a brain after a brain surgery. And the idea, what they're trying to tell us is, you don't have to have shielding because it's not a radioactive source. It mimics HDR dose rate at, at a reference position. It can give you a gray a minute, and the RBE are similar to doing high dose rate. And then the treatment times are compatible. So what's not to love about that? I mean, it's attractive that you don't have to have isotope. It's attractive that there's a cost per unit. It had a great calling on the West Coast, I believe. I saw people use it there was a breast probe and various other things like that. That I think of Zeiss's model was a breast probe, but I don't think it's here to stay. Personally, maybe you do. Just feel free to pipe up. And then a few other just lovely things I just wanted to show you. So, diagnosis, keloid. So, and what happens, as you can see, this fellow, when he was a teenager, got a piercing. And then for his trouble, 2 years later, he had this what's called dumbbell keloid. So now, it's a cosmetic area, both male and female. And so one of the uses of the high dose rate afterloader, very expediently, is to make a little, almost like an ear clip with catheters and some flab, and then to basically give it 3 treatments, and off they go. And it's beautiful. And what you can do is shield with lead plates all the way around the ears and everything. So that's really good, especially in children. You don't want to be giving them any radiation. So then that's just kind of these are case studies. Now, we're about 15 minutes. Do you want to sort of have questions? I want to show you one more before I go.
More slides? Yeah, go ahead.
So that was the ear for keloid. This is the penis for a superficial skin cancer, where the surgeon's answer, may God forgive me, is to just amputate. Just a no mercy, no nothing. So what we were able to do for this fellow is make him a skin wrapper, and then around the base of his penis, put down these little surface applicators, and then treat him. And I believe there's a dosimetry picture, one of my favorites, by the way, here. So what we've got to do here is just see that you can have the external skin is getting the 100%. The external skin is getting 100%. There is the, an axial on the, and then the rest of it is getting relative sparing. Okay, so that I think that idea that we would, the idea here is that we would consider organ preservation in areas like the penis. There's another subset of folks, I don't have a good picture, where if there's a superficial cancers of the vulva, the surgery is a radical vulvectomy, which is removing the labia majora minora clitoral hood, and it's very disfiguring. It's very painful. It makes it impossible for them to have relations and so forth. So it really is quite something to do that. Now, I'm just there are in fact another 30 slides. Let me just zip through these quickly, see if there's anything I really want. Oh yeah, this is the one I wanted. So this is then a facial angiosarcoma. The eyes are prohibitive for beam, as it happens, and so we were able to make this surface applicators to be able to treat definitively. And so just show you. This is actually, I wanted to show you the pictures more than anything. This is I believe a Merkel cell cancer. I think this is this margin like this is angiosarcoma, and what we see, this is the flank of a really large person, and we're managing to do surface like that. So you see surface, surface, surface is what these are all about. And then the rest of it is the treatment planning talk, but I thought the pictures were sort of really good. Okay, so, and then I think we've seen these with sort of foot, forearm, keep going. This is just another key. No, it's a lymphoma. I think this one, pretty nifty. Give it a 2 centimeter margin, treat it, and and then this is the idea about covering up with the lead lining, so you no scatter to normal U. All right, and then does the dose distribution, the lateral foot cutaneous lymphoma. I'm just going to go through this really quick. And this is actually the most famous one of all. So this fellow, professor at Harvard, had this thing on his foot there for 15 years, such that the surgeon was just about to amputate his leg. And he came in to see us on a knee scooter, a sort of a way you prop up your foot on a scooter. And he'd recently been to see a new dermatologist who actually got molecular genotypes on him and found he had a cutaneous lymphoma. So the day he came for treatment, you can see the red, desquamated, ulcerated. This picture is 6 weeks later, where he's had surface brachytherapy 4 gray times 2, and he has done a 6-mile hike on Cape Cod. How about that, huh? So let's just see what else we've got here. There's arms. Fingers. Now, just a few of these things that do matter. Sometimes brachytherapy can treat really big things. Other times, brachytherapy could treat little things. So this is a lady who had a Merkel cell on where your wedding ring is, and they're on the dorsum of the finger, and it gone all the way down to the tendon, still got a positive margin. The oncologic answer is a ray amputation like this, ray amputation like this. And so the answer was, let's try to give her adjuvant brachytherapy as her treatment. So she needs the equivalent of 66 gray. We're going to slightly dose and hypofractionate that a bit and get her down to a level where at the last day of treatment, so if you can see, so this is how we made the applicator itself. And this is, see, yellow is our 100%. You see how it is so conformal. You can do even with the tiny target. And then we have down on the bottom in the middle, that's what she looked like the day of end of treatment. And then what she looked like, this is at 1 year and 2 years, because of that, with the perfectly normal set of hands and fingers. So relatively simple to do. It's just quite amazing to do. And we'll hold on, we're going to stop in about a minute. Okay, let's just show you. This is an angiosarcoma. This is the actual noggin itself. It came out, all the margins were positive. And then what we do with that is we take 5 centimeters around, all the way around. You can see this is the front, it's getting towards his eyes here. And so there you can see that applicator coming down on him all the way down and get to do a beautiful dose distribution. And he is still cooking along, doing very, very well. And everybody said he should die of his cancer, but he didn't. So I'm quite proud of that. Anyway, there are a few more cases, but I think in the interest of time, we'll stop sharing and then let you see if there are any questions that folks are interested in.
Oh, super amazing lecture. Thank you so much. It's impressive amount of work, and I see how dedicated you are to brachytherapy. I understand why you call it love, love of your life.
Right.
2 books and so many patients treated with brachytherapy. It's quite incredible. Thank you for showing us all your interesting cases, and hopefully a lot of Ukrainians would get inspired by all this experience and would want to start new programs. That's kind of the goal of this course, right? So I would like to open the floor for questions. I see one question in the chat from Sergei Brovchuk. What dose per fraction do you use for keloid treatment? You showed us one of the examples.
Yeah, so that's had a check of the history of 4 gray times 3 and 7 gray times 1. There's like a lot of different fractionations, but there was a beautiful paper out of gosh, I can't remember what that, but actually, so the control rate in the experience of the lower doses was around the 80 or something percent. And so it's a very nice paper, which I'll remember, I can send it to you, basically said 6 gray times 3 to conformal 100% with normal shielding. And that then is 95% control. So that's what we have adopted for about 10 years.
Do you treat them also with electrons or only brachytherapy?
I think, well, we didn't even get to electrons. Now, here's the thing. Electrons are brilliant for flat surfaces.
Right.
Brachytherapy is equally brilliant for flat surfaces. Hold on. Electrons are rubbish for big curvy surfaces, and brachytherapy is excellent for curvy surfaces. Okay, and so the role of the electron, where it's a flat on fast thing, is fine. A little bit of curvature, fine. But that in general, you've got complicated things that need some high elevation of dose. There's no homogeneity in that. Like one of the examples was given to us last year, I think it was somebody had a post mastectomy scar recurrence, and she had been reconstructed with a tissue of her own tissue, but she'd grown a cancer right inside the wound, a recurrence. And so that was something that we needed to get that, we resected that and put it back together and everything, but we needed to get that to 50 or 60 gray just because of that recurrence there. And she made it by us. We actually planned it with electrons. They're like 3 electron beams, looked terrible. And so we went back and did it with brachytherapy, and I'm biased, as you're getting.
Yeah.
The brachytherapy was great, and she did fine, thank goodness.
Oh, excellent. You know how we fight this surface issue is with variable surface bolus.
Mm-hmm. Yeah, and I think that if you can find it, the 3D custom bowls printed, and we've used that successfully on the vulva. By the way, when we couldn't get brachytherapy in there, we didn't think it was deep enough. We're very open to it. Lots of head and neck sites, noses, ears, stuff like this. If you can then reduce the clinical target to something the electron is going to be homogeneous over and not other, right? That's really the long and the short of it.
Yeah, excellent. There is another question from Dr. Sokolovska. Dr. Devlin, thank you so much for the amazing lecture. What's your favorite localization for brachytherapy and why?
What gives me joy?
Yes.
I think it's the really delicate things where there is a big human disfigurement. There is a big risk of a bad amputation, and the taking that patient and being able to give hope to the patient that they can have, the 3 things I didn't tell you who told us. So the chief sarcoma surgeon at Memorial Sloan Kettering was Murray Brennan, and Murray was a wonderful teacher, and we liked each other. And so he said, Philip, the patient only wants 3 things out of you. Don't get away with yourself. Don't think you're so important. The patient wants save my life, save my limb, and save its function. So the joy of my job, because it's a teaching hospital like yours is at Stanford, is that folks roll in the door where in the community hospitals they've not been able to do something, and so I'm a great fan of expanding the scope of the practice. What I didn't show was really that we, working with the ABS, we're out doing workshops in gynae. I think there's a gynae one around the corner here. I think they're in head and neck. They're in various sites, and so we're doing workshops. We do visitorships where somebody comes for some amount of time that they can afford to come away. We have formal fellowships of 1 or 2 years duration, and we've got enough business, so to speak, that more than one fellow can easily enjoy. We are teaching the residents. There was a question about a residency just popped up in and out of the chat. So the Jack Estro, I think, has done a beautiful job. Very small, medium-sized meetings everywhere. And I think even the corporations, Electa and all these people, Variant, Electa, all these people are also trying the best to propagate it, not necessarily to make the money, but I think to propagate it so that we can give people the hope that I hope I have at least spread a bit to you.
Yeah, that's excellent. Thank you. And there was a question in the chat also from Dr. Matzak. How do you keep up the knowledge for brachytherapy now that external beam is moving into more of a AI, artificial intelligence, things are done for you. And then in brachytherapy, you still have to do things manually, right? Insertion, surgical work, like a surgeon.
Yeah. Yeah.
How do you keep this going, keep brachytherapy alive with training new generation?
Yeah, that's why I spent my life here in the university hospital teaching them, and I hope to do so for a lot longer. And I have great picture over behind me, and there's a picture, and that's a photograph of my first 9 fellows who all came to teach a brachytherapy course with me in Boston. All 9 of them. That was a few years ago, and I only had 9. And it's so that they are established as professional, subspecialty trained, and now it's trained at Harvard, trained by Devlin, all this stuff, but it's sort of like it is quite lovely to see their ingenuity, and they're not copycatting Phillip Devlin. They're doing their thing.
Their own
You know?
thing.
Yeah, very, very much so.
Excellent. So that's very inspirational. So you're bringing up next generation. Excellent. Do you prescribe brachytherapy for facial hemangioma?
No, I have not seen it. We've had lots of facial cancers and facial lymphoma, but I think if there was, it would be an interesting conversation as to what's the target, what's the dose, and what's the deficit side, and is there a risk of a radiation-associated malignancy? I'm sure of that, but we would sit and listen. We have a children's hospital like you do, and there are children's hospitals in Ukraine. But I would say that we'd sit and listen. And what you often know, you hear people try it on, then they try it on, they all run away scared. And so we're there present as we see how people will push the boundaries. If anybody in your group has done that, I would love to hear about it. We could maybe write a case report, something like this to teachers. I haven't seen one that I can remember. And I do edit for the Brachy Journal, and I'm the section editor for everything else. So I usually do see even case reports.
Okay.
Great question.
Thank you. And then there's another question from Danilo Kovalenko. Which approach is better, using beta minus brachytherapy sources, applying an external electron beam for low energy X-ray for skin treatment?
Yeah. So it's lower energy electronic X-rays versus what?
For low energy X-rays, electrons versus beta minus brachy sources.
Oh yeah. I'm not sure I've thought about that. I would have to think about that and look at it. We don't have a lot of beta minus sources actually around in our we have got strontium for the heart, we've got yttrium for the livers, but we don't have any others like the what are those things called again? Stick them in your eye. I think it's strontium, isn't
it? Ruthenium. That's for eye plaques, right?
Right. That's for corneal melanoma and for retinoblastoma in the children. Although the fact that it's not shielded on the back of it raised the specter of a secondary osteosarc, essentially triggered by the RB gene. So that's a tough place to do retinoblastoma with kids anyway.
Question from Dr. Brovchuk. Thank you so much for a great lecture and answers. What do you think about a place of immune therapy, immune response as part of the brachy treatment?
Yeah, I think I've absolutely got to start exploring that in every front responsibly with what we do, and it's all very, very common and present, like in our lung cancer beam practices, just think of some others here in a minute. But it's sort of it's the way of the future, which is a double-edged sword. It can do more good for sure, but also the whole pattern of what the side effect profiles look like from trimodality therapy, including immuno, are not necessarily the same as what they are just looking at immuno alone or just chemorads alone. So I think it's being approached responsibly, cooperative groups, trials, and so I think that is going to be some of the way of the future.
Are there any trials looking at specifically brachytherapy plus immunotherapy?
I don't know, but I wouldn't be surprised they're in advanced cervical cancer is where we're going to find them.
Yeah, sure. Sounds good. And maybe the last question, if I may, I know it's over time a little bit.
Oh, we're good. They're not barking at the door yet.
Okay, so you are a visionary. You built a great, amazing program at Harvard. You've trained many fellows that now are training next generation as well. Where do you see brachytherapy is going? So what do you think the future holds for brachytherapy?
I think brachy will stay steady. I think it's inexorable over the two big prostate end of the gynecological cases that it has to stay steady. And then the question is how much general integrates in, and so my idea to show you, I can see Zoe Shepil. I do not think that brachy will be replaced 100% with EBRT, no matter what they do. Anyway, so that's just a little bit of my enthusiasm. We need to have both. We need to train for both. The young folks need not to be too scared of it, and so I think it's still there. Yeah. And by the way, over all these decades, things have come and gone. Oh, it'll be the end of prostate. It isn't the end of prostate. Surgery will change gynae. It isn't the end of gynae. And so we our fashions based on evidence, based on unanticipated side effects. It keeps us honest and keeps us sort of trying to fine tune as we go along. And I think we'll keep doing that.
Thank you so much. Thank you. On this positive note, we'll end this lecture. Thank you again for your time and preparation for the lecture. Thank you for teaching us and inspiring us to do more brachytherapy, learn more about brachytherapy. And this course hopefully will provide a great overview for Ukrainians to possibly start new programs. So we hope so, or improve their existing programs.
Right.
So we are looking forward for next lectures. Thank you again. Bye-bye.
Take care, my friends. Thank you. I'm honored. Thank you.
Thank you so much.
Thank you.